So we are just getting ready to induce and intubate, and before we do that, we want to make sure that our assistant knows how to properly hold for intubation. So, Ms. Jessica, we need to make sure our patient stays sternal. You're going to be holding your head up by the lips only. You don't want to put your fingers in the mouth so you don't get bit. And then in order to keep her sternal, the easiest way is to get your elbows on either side of her chest right here, and she won't wobble on us. Okay, so we're going to be using Propofol as our induction agent, and we're going to titrate to effect is the way that we're going to give this IV. And what that means is we're going to give half of the dose over 30 seconds. So when I get started, I'm going to let my doctor know that I'm inducing. I'm going to make sure I check my watch, and I want to give it a nice fluid motion. I don't want to be stopping and restarting. It can take a little bit of practice, but you just want to give it a nice smooth motion. I do want to warn my assistant that one of the side effects of giving Propofol too quickly is apnea. So Ms. Jessica's going to make sure our patient is breathing as she's restraining. Another thing they can have is the myoclonic twitching, which is when your assistant may be in danger because they could close their mouth really hard. So that's why she's only going to be holding by the lips. I'm going to put this directly into the catheter when I'm ready to do that. But again, I want to just make sure I have all my supplies. I have a laryngoscope with an appropriately sized blade for this dog. I am going to go ahead and make sure that it's working. I'll turn that back on before I get started. I have a tie to tie my tube in. You don't have to do this, but I personally like to go ahead and put a little tie in it so it's ready to just slip over my tube. You want to make sure when you tie this onto your tube that the ends are fairly even. If they're not, they'll actually twist the tube inside the patient. I'll leave myself enough room to slip it over. Then I'm going to take my sterile lube and I'm going to lubricate my tube. I really want to focus mainly on the cuff here. That's really where it's going to get bound up. I've took all the air out as much as I could so you can see it's nice and raisin-like. Dump my, she's ready. Dump my sterile lube there, and I kind of just use my paper towel to make sure I get it on every side. Then I'll just sit that there.
We want to be sure that we don't get lubricant into the end or the Murphy's eye.
So this is your Murphy's eye. You want to make sure you don't get lubricant there. And then I will also have a piece of gauze because when you go to pull the tongue out, it can be a little slippery if they've been hypersalivating. And I guess really quick I'll go through the hand motions because when we do the intubation video, we're just going to go right through it. So what I do is I will titrate to effect my Propofol. I'll give the half. I will go ahead and have my assistant then grab the lips and get into position, extending the head out. And I'm going to check her reflexes. So I need to decide, is she ready to intubate or not? So she should start to be closing her eyes, and her eyes may even go rostral. I'm going to check for jaw tone before I put my hand in her mouth. So I should just pull on her incisors, and she should have a pretty loose jaw. I can then try to pull the tongue, and if she allows me to, then that's our go time. So I'm going to take my gauze. I'm going to pull the tongue out with the gauze. Okay. Then I'm going to grab my laryngoscope. I'm going to set it. The blade is supposed to sit on the tongue. This is not meant to pull the epiglottis down or do anything in those structures back there. It's specifically meant to just push the tongue down and then give you light down the throat. So I'm going to angle it and put it in the position I want, and then I'm going to also switch it over to my non-dominant hand. I want to intubate with my dominant hand. Once I have that in place, I'll grab my tube and I will go ahead and make sure I visualize. You don't want to just throw this tube in. You want to visualize the arachnoid cartilages and see that epiglottis. If the epiglottis is in your way, and it may be, you're going to use the tube to pull it down. I might need to move my light a little bit and make sure that I again see that V and I see the cartilages of the larynx, and that's where I want to go through. If you don't visualize first, you almost inevitably end up in the esophagus. I would expect her to cough if she's not too deep, and then I know I'm in the right spot, and I will tie it into place. So those are the hand motions that you'll be doing. Once you get it in, you can put your laryngoscope down and worry about tying it in. So that'll be our next video.